Hi guys, so welcome to podcast 9 of Let's Revise MBBS, and today is going to be a session of MCQ challenge. Right, so this is the first time I am doing this, so let me explain how I am going to do it, why I am doing it, and how is it going to help you. Okay, so how is this going to proceed? So I'll ask you a MCQ. Okay, it can be MCQ or it can be a one-word answer. Okay, then I'll wait for around 3 to 4 seconds. You can answer to yourself between that time, and then later I'll give you the answer, and then we will also see its explanation. And for most of the questions we will ask a question why, like why is this the answer, or what is the mechanism behind this, and we'll try to explain that mechanism also. Okay, for whatever questions that is possible. So again, why am I doing it? So we covered almost 8 podcasts now. So I realized that I am giving information, I am reading, I am studying, and I am giving you that information. But I should also learn to apply it, and after application I should be able to tell you that why was the answer A and not B, C, D. How did I rule out other options, and how did I come to a conclusion that the answer will be A. Obviously, while solving, even I have made a lot of mistakes, and then I read about those MCQs in detail. I read about all the options in detail, and also tried to give explanation to myself, like why are the other options not correct. And I did it for all the MCQs that I'm going to discuss with you, and that's why it's helping me a lot. And how will it help you? So obviously, I'll give you correct information, and as far as possible I'll try to give you 100% correct information, and you will not need to read or waste your time on researching or reading those topics and opening your textbook, opening that page number and reading that topic to come to a conclusion that the answer will be B. For most of the MCQs I'll tell you why is it B and why not A, C, D. Okay, so that's a short introduction. So let's begin with today's podcast. So the first question is, the folds of Hoboken are found in the amnion, the placenta, uterus, or umbilical cord. Right. So the answer is umbilical cord. So what are the folds of Hoboken? So we have discussed that umbilical cord has 2 arteries, 1 vein. So when we cut the umbilical cord, we tie it physically, but also there should be some natural mechanism which prevents the bleeding from the umbilical artery. So these folds of Hoboken are actually myofilaments which are present in the basement membrane of umbilical arteries. So when we cut the umbilical cord and when the fetus is delivered, these myofilaments contract and they form circular band-like structures, and this helps to prevent bleeding. So this is known as fold of Hoboken. Okay, coming on to the next question. The second question, fetal sex can be detected by USG at 14 weeks, 16 weeks, 18 weeks, 20 weeks. Right, so the answer is 14 weeks. Why? Let's go back to our podcast 1 and 2. So there I have discussed with you the development of the fetus. So the first line of the podcast was that the gonads are bipotential till 6 weeks. Then at 7 weeks testes are formed. At 8 weeks ovaries are formed. Okay, this was about the gonads. And about external genitalia, first at 12 weeks female external genitalia is formed, and at 14 weeks male external genitalia is formed. So at the end of the 14th week or at the 14th week, we can surely say by the USG whether it is a girl child or it is a male child, right? Because by the 14th week, both, if it's male, his genitalia are developed. If she is a female, her genitalia are also developed at 12 weeks. So the answer is 14 weeks. Coming on to the third question, what is altered in thyroid profile throughout pregnancy? Okay, first option, free T3 levels. Second, free T4 levels. Third, total T3 levels. And fourth, TSH level. Right. So the answer is total T3 levels. So we have discussed this in endocrine. So we said that the thyroid hormone starts secreting T3, T4 in excess level than in normal. So in pregnancy, the level of T3, T4 increases. But this is total T3 and total T4. Okay, but I told you that free T3 and free T4 remain same. They do not change. So only total T3 is increased. Right? So the answer is total T3 levels are changed. Okay. Coming on to the next question. Fourth question. Which of the following decreases in pregnancy? Respiratory rate, vital capacity, functional residual capacity, inspiratory capacity. Right. So the answer is functional residual capacity. Okay, it's logical. See, we had discussed that the uterus enlarges, it pushes the diaphragm upwards, and therefore the residual volume decreases. If the residual volume is decreasing in pregnancy, obviously functional residual capacity will also decrease. Okay, what is functional residual capacity? It is expiratory volume, like expiratory reserve volume plus the residual volume. So if the residual volume is decreasing, FRC will also decrease. So the A option was respiratory rate. It remains same. It does not change. Vital capacity also does not change. And D option was inspiratory capacity. So we had seen that because of the increase in transverse diameter by 2 centimeters, the tidal volume increases. And inspiratory capacity is tidal volume plus inspiratory reserve volume. So if the tidal volume is increasing, IRC inspiratory capacity will also increase. Therefore only FRC will decrease. Coming on to the fifth question. In pregnancy, the diaphragm is elevated by 1 cm, 2 cm, 3 cm, 4 cm. The answer is 4 cm. Straightforward question. No need of any explanation. Just remember, the diaphragm is elevated by 4 cm and the transverse diameter of the chest increases by 2 centimeters. Okay. Coming on to the sixth question. The term placental sign denotes A. Alteration of fetal heart rate on pressing the heart into the pelvis. I repeat, alteration of fetal heart rate on pressing the head, not heart, the head into the pelvis. B. Spotting on the expected date of period early in the pregnancy. Permanent lengthening of the cord in third stage of labor. And D. Slight gush of bleeding in third stage of labor. Right. So the answer is spotting on the expected date of period in early months of pregnancy. So what is placental sign? See, we had talked about deciduo capsularis and deciduo parietalis. So deciduo capsularis is the part of deciduo which covers the developing embryo or fetus. Okay, and deciduo parietalis is the part of the uterus or endometrium which is away from the fetus, which is not in contact with fetus. Right. So what happens at the 12th week or up to 12th week, there is deciduo capsularis and deciduo parietalis are not fused, they are separated. So there is cyclical bleeding, scanty cyclical bleeding going on till the 12th week, and so there is scanty bleeding every month, right? But after 12 weeks, this deciduo parietalis and deciduo capsularis fuse together, and after that there is no bleeding. So this is called placental sign. Okay. Coming on to the seventh question. In pregnancy, vaginal cytology shows predominance of intermediate cells, superficial cells, basal cells, parabasal cells. Right. So the answer is intermediate cells. So basically there are three types of cells in the vaginal epithelium: parabasal and basal, intermediate cells, and superficial cells. Superficial cells are mainly increased when there is estrogen predominance. So that is in the reproductive period, in the entire reproductive period. Intermediate cells are mainly predominant when the main hormone is progesterone, and this is during pregnancy. and basal parabasal cells are maximum when there is no hormone or there is lack of any hormonal activity. So this will happen after the menopause or before the menarche, right? So 3 types of cells. Coming on to the next question, which is question number 8. Time taken for the capacitation of the sperms is 2 to 4 hours, 4 to 6 hours, 6 to 8 hours, 8 to 10 hours. Right. So the answer is 6 to 8 hours. So what is capacitation? It is the ability of the sperm to fuse with the ovum. Okay, what actually happens in capacitation? There are 2 effects. One is that there is destabilization of the acrosomal cap of the sperm so that it can easily penetrate the outer layer of the egg. And second is that there are some chemical changes which happen in the tail so that it can allow the sperm for a greater motility. Okay, so this change, whatever these changes happen, are mainly facilitated by the removal of sterols, which are cholesterol, and some glycoproteins. Okay, because of removal of these compounds, the permeability increases and there is more calcium influx, and therefore the sperm acquires more motility. Okay, so this was about the concept of capacitation. What is the where does this capacitation take place? Mainly in the fallopian tube. Okay, now coming on to the next question, which is question number 9. Multiparous pregnancy predisposes to all except PPH, B. preeclampsia, C. anemia, and D. malpresentation. Right, so the answer is preeclampsia. So we haven't covered preeclampsia or PPH, but you can guess. So what happens in multiparous women? Already the tone of the uterus will be less in multiparous women if you compare it with nulliparous or primi. Okay, the tone of the uterus would be less. So if the tone of the uterus is less, it will have more chances of postpartum hemorrhage. Okay, so it will also have more chances of malpresentation because now the uterus is bigger in size, the baby has more room for movement, so malpresentation will be common. And anemia, obviously, during each pregnancy the demand of iron increases, and if she is not consuming properly the iron tablets, etc., she can have anemia. So chances of PPH, anemia, and malpresentation all increase in multiparous women. But preeclampsia, it is the hypertension which occurs during the pregnancy and the proteinuria. We'll discuss about this in detail in the further upcoming podcasts. But what is the exact pathology of preeclampsia? That I guess we'll discuss this in next podcast. But by elimination, we could come to answer option B, that is preeclampsia. Okay. Coming on to the next question, that is question number 10. Rule of Hasse is used to determine the age of the fetus, height of an adult, race of a person, identification. So the answer is obviously the age of the fetus. The options were quite easy. But can you recall the Hasse's rule? So we had 2 parts. First, if the mother is less than 5 months pregnant, and if she is more than 5 months pregnant. So to determine the age of the fetus by the USG, we can determine the first the length of the fetus. If the length of the fetus is suppose X and the woman is less than 5 months pregnant, so we divide X by 5. We take the root of X, and whatever number we get, that is the age of the fetus in months. This is for less than 5 months. If the pregnant woman is more than 5 months, we do X upon 5, and whatever answer we get, that's in months. So that is the age of the fetus in months. Okay. Question number 11. Millard's rule of 10 includes all except 10 pounds, 10 weeks, 10 gram%, 10 months. Okay, so the answer is 10 months. So even if you don't know about Millard's rule, one option is 10 weeks and the other is 10 months. So answer should be obviously between these two, right? That we can guess, and we can mark one of those. But let's see what is Millard's rule. So if a child is born and he is having cleft palate or cleft lip. So when do we do surgery for this repair? So we do it when the weight of the child is 10 pounds. 10 pounds is approximately 4 to 5 kgs, right? When his age is 10 weeks. So 10 weeks is almost 2.5 months, right? So in about 2.5 months, his weight will be around 4 to 5 kgs. So 10 weeks, 10 pounds, and his hemoglobin should be 10 gram %. So if these three criteria are fulfilled, then we will take that child for surgery of cleft lip. Okay, 10 months is the answer here, since except was asked, right? So moving on to the 12th question. A placenta that has a chorionic plate smaller than the basal plate is membranaceous placenta, succenturiate placenta, circumvallate placenta, and fenestrated placenta. The answer is circumvallate placenta. So let's see, what is membranaceous placenta? The placenta is made up of membranes, okay, and it covers the entire chorion. Okay, so that's not the answer. Second is succenturiate placenta. So we had discussed succenturiate placenta has two lobes. One lobe is bigger, the other lobe is smaller, and those two are connected by blood vessels. Okay. Circumvallate placenta. So we had seen two types placenta, circumvallate and circummarginate. That the maternal side of the placenta was bigger than fetus and it was covering the fetal placenta. So here the answer is circumvallate. And the next option was fenestrated placenta. What is fenestrated placenta? Here the central part of the placenta is missing. Coming on to the question 12. Appropriate treatment of women having edema in pregnancy includes salt restriction, fluid restriction, diuretics, bed rest. So the answer is bed rest, because as we have seen that edema is quite common in pregnancy. We do not need to do anything, it's physiological edema, so just give her bed rest. Next, question number 13. Which of the following cardiovascular change is abnormal in pregnancy? A. Enlarged cardiac silhouette. B. Increased S1 split. C. Right axis deviation on ECG. And D. Early diastolic murmur. Right. So the answer is, we have two answers here. Right axis deviation and early diastolic murmur. Okay. A option is enlarged cardiac silhouette. So the border of margins of the heart may be increased. We have seen that there can be mild cardiomegaly. So A is not a abnormal finding. Increased S1 split, yeah, S1 can be loud and it can be split. So that's normal. Right axis deviation, no. There is left axis deviation. Why? Because uterus is dextroverted and it will push the heart to the left side. So right axis deviation is an abnormal finding. And our early diastolic murmur, no. I told you that any kind of diastolic murmur is abnormal in pregnancy. Systolic murmur, early systolic murmur, if it's grade less than 3/6, it's okay. But if it's more than 3/6, it's not okay. But here diastolic murmur is given, so any kind of diastolic murmur is abnormal. So answer will be both C and D. Question number 14. False statement regarding HCG is: it is secreted by cytotrophoblast, it acts on same receptors as LH, it has luteotrophic action, and it is a glycoprotein. So the answer is A. It is secreted by cytotrophoblast. See, we had discussed that HCG has two subunits, alpha and beta, and alpha subunit is similar to LH, FSH, and TSH. So it can act like LH. So it can have luteotrophic action. It can also act on LH receptors, and it is a glycoprotein. So B, C, D, all the three options are correct. But A option, which says it is secreted by cytotrophoblast, is wrong. It is actually secreted by syncytiotrophoblast. Okay. So coming on to the last question of the day, question number 15. Best test for estimating HCG: radioimmune assay, ELISA, radio receptor assay, bioassay. So the answer is radioimmune assay. This is a kind of factual question. So what we do exactly in radioimmune assay is that we detect beta subunit of HCG. So it is specific because beta subunit is specific for HCG. It is not same for any other hormone, and it is specific. One thing it is specific, another it is very sensitive. So it can be detected. We can detect HCG in urine as early as 8 to 9 days by this method, by radioimmune assay. So that were 15 MCQs for you. Let me know how you felt about this, and I would like to hear your feedbacks about this. Right? Till then, keep studying and enjoy. Bye bye.